it's my pleasure to introduce Dr. Sushmitha Shri Ganesh, who is a cornea, cataract and refractive consultant at Netradhama Super Speciality Eye Hospital in Bangalore with us. And today she is going to give one of the most complex subjects that we actually have today, which is the IOL power calculation in special situations. Now, these situations can be post-refractive surgery, post-RK, keratoconic eyes, and post-corneal grafts. So we're very excited to hear this talk, and over to Dr. Sushmitha.
Thank you, and good afternoon to everyone present here. So today my topic for discussion is IOL power calculation in special situations. So what are these special situations that we can come across? The first one, which is most relevant to this IC, is post-refractive surgery. A lot of people are undergoing refractive surgery, especially PRK, LASIK and KLEX these days. The global demand for refractive surgery has increased quite a bit, with a compounded annual rate of increase of about 4% from 2019 to 2024 itself. So this group of people are the ones who will come to us in the future for cataract surgery and demand a good refractive outcome. The next group is in corneal ectasia. Various studies have shown in India a prevalence of keratoconus to be from 0.6 to 2.3%. Also, some studies have shown prevalence of subclinical keratoconus in the patients undergoing cataract surgery to be as high as 27.5%. So it is important in these patients as well to give good refractive outcomes. Then comes a small niche group of patients who have undergone keratoplasties such as PK, DALK or even endothelial keratoplasties, and it can be quite challenging to perform biometry in these cases. So the first is post-refractive surgery. These patients will come to us with quite high expectations because they've had spectacle independence for most of their life, and they usually come requesting for premium IOLs. And the challenge for us is that certain studies have shown that less than 70% of eyes who have undergone refractive surgery as well as cataract surgery have a target refraction of plus or minus 0.5 diopters. So what are the sources of errors that we usually encounter? This is index error, instrument error, and formula error. So in index error, we can see that in post-myopic LASIK or PRK, there is a central flattening of the anterior curvature. In post-RK, there is a flattening of both the anterior and posterior curvature as well as mid-peripheral steepening. In post-hyperopic LASIK, there is a central steepening. So the keratometric index of 1.3375 is usually assumed if there's a constant relationship between the anterior and posterior radius of curvature, which is the Gall-Stranz ratio. However, in post-refractive surgery, this is altered. So we cannot consider this standard keratometric index, which is used in the usual IOL formulae for estimating the effective lens position. The next error is the device error. Most manual keratometers and autokeratometers take the measurement from the paracentral cornea in order to get a SIM-K which has the assumed central corneal power. However, in post-refractive surgery, usually this leads to a false high K value. So in myopic LASIK, PRK or SMILE, there is an underestimation of the IOL power leading to a hyperopic surprise. Whereas in hyperopic LASIK, there is an overestimation of IOL power leading to a myopic surprise. So how to tackle these errors that we come across? Various biometers are available to us, such as the IOL Master 700, which uses the telecentric keratometry and swept source OCT in order to get the total keratometry. As Dr. Shreyas has already mentioned, this takes into account both the anterior as well as the posterior corneal curvature, and also has the integrated Barrett TK formulae. Also, we have various other Scheimpflug-based topographers and OCT-based biometers which help us calculate the anterior and posterior corneal curvature. There's also correction factors which can be taken into account for the corrected keratometric index. These devices, which have already been discussed, help us calculate the true net power, total corneal refractive power, as well as equivalent keratometric readings, which can help us get more accurate K readings post-refractive surgery. The third error is formula error. The various Vergence formulae that we use take into account the axial length as well as the K for the effective lens position estimation. However, post-refractive surgery, there is a flatter K. This leads to an underestimation of the ELP and an inaccurate IOL power calculation. So there are various formulae that over time have evolved for IOL power calculation in post-refractive surgery eyes. One is the historical data, which means we need both the pre and post-operative K values as well as the refraction in order to use these formulas. I will not go into detail too much about this because it involves a lot of mathematics, but some of the time-tested formulae that have been used are the partial history method, where we take the pre and post-operative K using the Aramberry double K or the Barrett true K partial history. However, this is a more practical scenario for us, where we get patients who have undergone refractive surgery many years ago and come to us with no historical data. So some of the formulae that can be used are refraction-based formulae like the contact lens method as well as the intraop aberrometer. There are certain post-operative K readings which can be taken in formulae which incorporate just the anterior corneal curvature, which have shown to be quite accurate, such as the Bangkok-Maloney, Sharma's PL, Haigis L, and the Barrett True K no history method. Also, taking into account the anterior and posterior curvature, the Barrett Universal 2 formulae using the Swepsos OCT devices give a very predictable outcome. Ray tracing formulae also have good outcomes. This is done by calculating the true corneal power. So the ASCRS online calculator is a very useful tool for us. It's an open access and free calculator that helps us calculate the IOL power in these kind of patients. They have 3 modules, both the myopic, hyperopic, and the RK module, and the formulae that are commonly used in this are the double K holiday, Sharma's PL, Haigis L, OCT based formulae, and the Barrett True K. So the IOL of choice, we have to take into account this as well when choosing, when doing our biometry. Myopic LASIK or PRK leads to a positive spherical aberration, so it's ideal to take a negative spherical aberration IOL, also an aspheric IOL. In hyperopic LASIK, it's reverse, where there is a negative spherical aberration, so we should consider 0 or positive spherical aberration IOLs. Toric IOLs, multifocal and EDOF IOLs can also be considered. These should be considered when there's a low refractive error correction that has happened, a perfect centration of the ablation, low higher order aberrations, and good EKR distribution curve. Just to make it a little more simple, this is a case of a patient who had undergone RK 35 years ago. RK scars present. The cataract was greater in the left eye, NS3cc with a myopic fundus. Best corrected visual acuity was 612 in that eye. So we performed a pentacam topography, and we saw that there was a pretty central flattening, and this is the EKR curve. So this is how we usually do it in our center. With the IOL Master 700, we calculate various formulae, usually the Barrett True K, Universal 2 TK, the Pentacam Central K, which is incorporated into the Barrett formulae, the Pentacam EKR Holiday 2, and the MS39 ray trace. So we compare all of these, and we have found in our center that the Pentacam Central K values provide quite accurate outcomes in post-RK patients. So the patient underwent surgery with this plus 23 diopter lens, and we try and target a little more myopia. And post-operative BCVA was 6 parts, with this being the refraction. The second case is in LASIK, with a patient who had undergone LASIK 20 years ago with cataract in the right eye greater than the left eye and BCVA of 6/9. So we performed the EKR maps, as you can see here, and right eye phaco was planned. In post-LASIK and post-SMILE cases, we usually consider these formulae: the Barrett Universal 2, Barrett True K, Barrett TK True K, Haigis L, Haigis TK, and Pentacam EKR Holiday 2. So we try and take the higher IOL power. Usually the Barrett True K is pretty accurate and gives a very predictable outcomes. The post-op refraction was 6/6 and 6, and this being the residual refraction. My next topic, which I'll go through quickly, is in corneal ectasia. The previous speakers have already touched on this. It is quite difficult to get the K reading as well as the axial length reading in these keratoconic eyes. The deviations are usually due to the deviation from the corneal refractive index, the visual axis being slightly displaced, an irregular tear film, and usually we encounter hyperopic surprise in keratoconic eyes. So keratometry and biometry can be done ideally using elevation-based topography devices rather than the manual and automated keratometers, because they are not reliable. Also, we prefer optical biometry rather than ultrasound because the visual axis does not coincide with the corneal apex. So these are the formulae that can be used for keratoconic eyes, but the most accurate keratoconic formulae are the Barrett Universal 2 formulae and the Kane keratoconus formulae. This is how they perform usually, and it is important to target a higher myopia in keratoconus eyes based on the degree of keratoconus and the formula that we used, as you can see in this table. Now, the IOL of choice is a monofocal single-piece non-spherical IOL. We should take, non-aspheric IOL. We can also consider toric IOLs if it's a non-progressive keratoconus. And as you can, I'll just briefly go through this case, which is both eyes keratoconus stable, left eye having more cataract, and you can see in the pentacam it is a pretty regular cornea. So we opted using the Barrett toric TK to undergo a toric IOL implantation. After the surgery, the patient had no residual refraction with uncorrected visual acuity of 6.6. Post-keratoplasty, it is quite challenging. As we all know, there's a change in both the anterior and posterior curvature in these eyes, which makes it difficult to do both the K readings as well as axial length. So usually in suture keratoplasties, we wait 2 to 3 months after complete removal of the sutures. Certain topographers help us get corneal true net power, and optical biometry is preferred. Also, 3rd and 4th generation formulae are preferred. In triple procedure, we can take previous cases, K readings done from the same surgeon, average estimated post-op K from literature, or even K values from the fellow eye. In DSEC and DMEC, it is important to note that there's a hyperopic shift mostly in DSEC, so we should target a myopia of at least -1 diopter. Ray tracing has also proved to be quite good. So there are various formulae that we can use, as already mentioned, but the IOL of choice, usually if there's a higher degree of astigmatism, we can do a stepwise approach where we first do femtosecond astigmatic keratotomies, usually greater than 8 diopter of astigmatism, or we can choose a toric IOL, which does help reduce the astigmatism. That's all for my talk. Thank you.